right. Well, I'd like to call this meeting to order. Do we have everyone? Perfect. Okay, thank you. I'd like to call the meeting to order. Honorable members, at the committee January 18th, 2022 meeting, the committee agreed that at the beginning of each meeting we would observe a moment of silent reflection and commemorate the lives lost in Alberta due to drug poisoning, overdoses, and to the illness of addiction. So we will do that now. Okay, thank you. Welcome to members and staff in attendance to this meeting of the Select Special Committee to Examine Safe Supply. My name is Jeremy Nixon, and I am the MLA for Calgary-Klein and the chair of this committee. I'd ask that members and those joining the committee at the table to introduce themselves for the record, starting to my right with our deputy chair.
Good morning, Tracy Allard, MLA for Grand Prairie and deputy chair of the committee.
Hey, Tanny Yao, Fort McMurray, Wood Buffalo.
Nicholas Milliken, MLA, Calgary Curry.
Good morning, Aaron Roth, committee clerk.
All right, now I'd like for those joining us online to introduce themselves, and I see MLA Rosen. Ms. Rosen, can you introduce yourself for the record? All right, well, when we get, oh, there we go. Thank you. Nope, they're talking, well, seems fine to us here. All right, and I see MLA Amory. Can you introduce yourself for the record? You are muted if you're trying to talk, MLA Rosen, or Amory. All right, we will just keep going then. I'd like to note for the record the following substitutions. None. Oh, that's amazing. Great work. Please note that the microphones are operated by Hansard staff and committee proceedings are live streamed on the internet and broadcast on Alberta Assembly TV. The audio and video stream and transcripts of the meeting can be accessed via the Legislative Assembly website. Those participating by video conference are encouraged to please turn off on your camera while you are speaking and mute your microphone when you are not speaking. Members participating virtually who wish to be placed on the speakers list are asked to email or send a message in the group chat to the committee clerk, and members in the room are asked to please signal the chair. Please let your cell phones and other devices be set to silent for the duration of our meeting. And we will move on to the approval of the agenda. Can I get a motion to approve the agenda? Excellent. MLA Al moves that the agenda for March 25th, 2022 meeting of the Select Special Committee to Examine Safe Supply be adopted as distributed. Any discussion about that? Hearing and seeing none. All in favor, please say aye. Aye. Any online in favor, please say aye. Any opposed, please say no. Oh, there we go. Any opposed, please say no. Okay, and from now on, I'll just ask that question collectively. So if you're online, say aye when I ask it, or when I ask for the people in person here. So now I'll move on to approval of, sorry. That was carried. Thank you. It's Friday morning. Up next is the approval of the minutes for the three previous meetings, February 15th, 16th, and the 17th, 2022. Are there any errors or omissions to note in relation to the minutes of February 15, 2022? All right, if not, would there be a member willing to move the approval of the minutes? Excellent. MLA Milliken moves that the minutes for the February 15th, 2022 meeting of the Select Special Committee to examine safe supply be adopted as distributed. All in favor, please say aye.
Aye.
Excellent. Any opposed? This motion is carried. Thank you. Are there any errors or omissions to note in relation to the minutes of February 16th, 2022? All right, seeing none, would a member move the approval of the minutes? Excellent. I got Emily Au moves that the minutes of February 16th, 2022 meeting of the Select Special Committee to examine safe supply be adopted as distributed. All in favor, please say aye. Aye. Excellent. Any opposed, please say no. That motion is carried. Are there any errors or omissions to note in relation to the minutes for February 17th, 2022? Hearing none, would a member move the approval of the minutes? Excellent. Emily Yao moves that the minutes for February 17th, 2022 meeting of the Select Special Committee to examine safe supply be adopted as distributed. Thank you, Emily Yao. All in favor, please say aye. Any opposed, please say no. That motion is carried. Okay, now we get to go on to the good part, on to oral presentations. Honorable members, at our February 17th, 2022 meeting, the committee agreed to invite additional stakeholders presentation in relation to the matters referred to us by the Legislative Assembly. Our first presenter today is Dr. Yo Go Lau. I apologize if I got that wrong. The Drugs and Alcohol National Coordinator in Portugal and Director General of the Intervention on Addictive Behaviors and Dependencies General Directorate. Dr. Golau, thank you so much for your time today and for joining us. Please proceed with your presentation. Oh, do we got you? There we go.
Hello. Good morning. Good morning to all. Thank you, Mr. Chair, for this kind presentation. I am very happy to join you in this discussion, even if I am not an expert on safe supply, because we do not have the experience. Anyway, here in Portugal, we faced a similar situation to the one you are now dealing with a huge number of overdoses deaths, huge problems related to mostly to heroin, some 2 decades ago. And I would like to share with you some views about how we dealt with those problems and make myself available for any queries that you might have. If you allow me, I will share my screen to share a presentation. Okay, it's there. Well, as I said, we faced a catastrophic situation back in the 80s and the 90s in Portugal, mostly related to heroin. And what I want to share with you is the way that we dealt with those problems. By the end of the 90s, drugs and drug addiction were the main concern of the Portuguese population. And we have 1% at least of the population affected by drugs problems. That means 100,000 problematic users, 98% of which were heroin users, 48% of them using the IV route. They contributed on 56% for the new HIV infections that happened in the country. We had around 350 overdoses deaths a year. And the response that was organized by our state was a new strategy that was approved in 1999, a new paradigm, the Law 30 of 2000, the Law of Decriminalization, probably the most known aspect of our policy. The creation of a national coordination. National coordination means coordination between different ministries that have something to do with the drugs problem. The creation of a national network of structures for intervention, building what we call the integrated model with a very close cooperation between the several components of the responses. The first Portuguese national strategy had two main components, the supply reduction part and the demand reduction, both based on the principles of humanism and pragmatism, and the traditional components of the demand reduction side were harm reduction, treatment, prevention, social reintegration. But on top of this, and assuming that we were dealing with health and social condition rather than a criminal one, the proposal was in the sense of decriminalization of every drug. We call to this and the bridge between the supply and demand side, we call the integrated approach, and evaluation is a crucial part of all the system. Starting with the dissuasion model, the subject of decriminalization, I'd like to say that the law 30 of 2000, the law of decriminalization, only changed one article of the drugs law of 93, a law that still stands mostly, and the article that was changed is the one that refers to personal use and possession for use. And it says the consumption, acquisition, and possession for own consumption of plants, substances, or preparations constitute an administrative offense. Possession cannot exceed the quantity previewed for individual use for a 10 days period. Exceeding this quantity, criminal procedures take place. So this means that the drug user is considered as a person in need of health and social care. This dissuasion intervention provides an opportunity for an early, specific, and integrated interface with drug users. So we consider it as an indicate prevention tool. And it is aimed and targeted to the drug user's characteristics and the individual needs. It's important to stress that in Portugal, the use of drugs is still forbidden. However, and unlike models from other countries, there are where drug courts were created with streamlined procedures under the Ministry of Justice, the commissions for the dissuasion of drug addiction privilege the health approach. They are bodies under the custody of the Ministry of Health. Of course, it only works if a coordination between services is present. All the services who may have any kind of responsibilities in this area, from employment and training services, addiction treatment centers, health centers, welfare services, prisons, and so on, schools, police authorities. So there's a network that is needed to make this system work. As I said, using drugs is still forbidden. And there's a long list of administrative sanctions that may be applied to people who use drugs or people caught in possession of drugs. However, never happens to have a criminal record who had clear benefits in the stigma and and allowing people to recover a normal life. The criminal record is usually something that impedes people to access credit, to get a job. There's a lot of difficulties that occur as a consequence of having a criminal record. It's as this list is a long one with many possibilities of administrative sanctions, it is possible to define sanctions according with the personal lifestyle and conditions. I would like to note that monetary fee is never applied to addicted persons. Just briefly, I would like to show some outputs of this system. From 2001 to 2020, we had around 150,000 offenders, from which 82,000 were assessed as non-problematic drug users, occasional recreational users, even though after the interaction with the health professionals, it was possible to refer them, most of them, 44,000, for specialized support, such as health support for other subjects or for social or psychological support, in any case, from the 15,000 problematic drug users that were assessed. 12,000 were accepted to be referred to treatment centers, treatment teams, and almost 10,000 actually initiated treatment in the centers of integrated responses. So it's a supplementary gateway for the system of treatment or to indicate prevention related to substances. In the beginning, when this law was approved, we faced some difficulties with the United Nations bodies, and it took some years until it was recognized that it was a good move. However, in 2016 at the UNGAS in New York, the president of the International Narcotics Control Board, the guardian of the treaties, stated that the Portuguese approach is a model of best practices fully committed to the principles of the drug control conventions, putting health and welfare in the center, applying a balanced, comprehensive and integrated approach, and based on the principle of proportionality and the respect for human rights. So since then, we feel much more comfortable with our approach, and somehow we open the space for other countries to follow the same via if they wish. Our policy is based on five pillars: dissuasion, and they anchor all the others: prevention, harm reduction, reintegration, and treatment. We have a quite solid network, public network of services for treatment that is complemented by regulated NGO and private responses. We have a high range of different models for intervention, but they are complementary and they allow a choice between the models to be followed or to be addressed by the clients and by the professionals. Along with this, we developed a set of strategies and programs in terms of harm reduction, from low threshold methadone administration to opioid substitution therapy and other dependence treatments, naloxone distribution, needle and syringe exchange programs, counseling, diagnosis and referral to treatment of drug addiction and of other physical diseases, information, education, and communication at the street level, using peer education in the party scene, for instance. Recently, we started the installation of safer use sites. We develop policies inside detention settings, prisons or youngsters detention sites. And we are developing recently as well the policy related to drug checking to assess what actually circulates on the street. I would like to take this opportunity to share with you those are some of the structures: street teams, refuges and shelters, contact and information points, drop-in centers, mobile outreach teams for the prevention of infectious diseases, cabinets of psychosocial support, and, as I said, supervised drug consumption sites. With this, we had some important results that I would like to briefly share with you. One of them this relates to the evolution of HIV infection that was really catastrophic in the mid-90s. This is the line of new HIV infections among people who use drugs. But since 2003, 2004, it dropped under the level of new infections among heterosexuals or homo or bisexuals. Nowadays, it's the contingent that is less represented in the new HIV infections in our country. On the other side, we have, as I said, by the 90s, the late 90s, we used to have around 350 overdoses deaths a year. Nowadays, and here in this graph, we have since 2013, 22 overdoses, 2014, 33, 2019, 63. There's an increase in the last years. We are trying to work on it, but in any case, we have the lowest number of overdoses deaths among the European countries. The new users that seek for treatment in the ambulatory public network have evolved like this. In 2011, we had 51% of heroin users. It dropped to 16% in 2019. Cocaine has been more or less stable from 15 in 2019, 26%. There's a slow increase in figures of cocaine. And nowadays, the highest number of new treatment demands relates to cannabis users. As you can see, new psychoactive substances or all the others remain in very low levels, around 5% of new treatment demands. Comparing with the situation in 1998. As I said, we had 1% of the population affected by drugs problems. Nowadays, we estimate that we may have 0.33% of the population. From the 100,000 problematic users, we estimate we may have 33,000 problematic users nowadays. From the heroin users, 98% in 98, we estimate nowadays we have 16% of all drug users using heroin. From the 48% using the IV route, nowadays we have 2% of people injecting drugs. From the new HIV infections, from 56%, we dropped to 3% among drug users. And from the overdoses there.
Sorry, Doctor. Sorry, that concluded our time, but I see you just have a couple more slides, so I think we all agree we'd like to see it finished, so thank you. Sorry to interrupt.
Sorry, Chair. Just to finish, next steps, we are just on the process of approving a new strategic plan. We will have next week a new government. We already presented a new plan that is based in 3 pillars: protect, care, and empower. And discussions on legalizing or regulating cannabis for non-medical purposes are already on the table. The issue that relates to safe supply has something to do with what about the other substances and regulating of other substances. Thank you, Chair, for your questions.
No, thank you so much, Doctor, for that presentation and taking the time with us today to jump across the Atlantic and spending some time with us today. So we really do appreciate that. We're going to dive into question and answers with the members here, but before we do that, if MLA Stefan can introduce himself for the record.
Hi there, MLA Jason Stefan, read to yourself. Thanks for your presentation.
Thank you.
Excellent. Thank you, MLA Stefan. We have MLA Amory up with the first question.
Hello, Dr. Gulau, and thank you very much for your presentation. I wanted to wish you a good morning, but I know that it's probably the afternoon where you are, so I appreciate you spending the time and presenting to us about this model of Portugal, which is sort of the gold standard, I think, when it comes to the type of discussion that we're having here this morning and the types of information that we're looking to extrapolate from this committee, from the presenters. Doctor, I want to talk a little bit about the process of change when it came to Portugal's decision to move with this model to deal with contemporary addiction and drug issues. I know that the system that you described in your presentation, and from what we heard in our other presentations, that this system involves or incorporates a number of different agencies and organizations that are all working together to try to accomplish a common goal, and that is namely to deal with the contemporary addiction and drug issues that all nations essentially face. I also know that from the description that you provided to us, that this system includes cooperation between the judicial system, police, organizations, and healthcare systems and whatnot to help work together and try to focus on the common goals that you described in your presentation with respect to the 5 pillars. I'm wondering if you can help us with a question that I have, and that is really with respect to police involvement, police enforcement. I want to know if you can describe to our committee what role the police in the Portuguese system, I guess. What sort of involvement, what sort of integration do the police have with respect to the model?
Thank you, sir, for your question. The police authorities are key in dealing with people who use drugs. We articulate very closely with them our strategy in trying to bring to the presence of the Commission for the Dissuasion of Drug Addiction the target groups that we choose together, and their activity is key in providing to the health system the opportunity to interact directly with those those people who use drugs. They have a quite friendly, say, attitude, but in any case, they are still, as I said, using drugs in Portugal is still forbidden, and enforcement without being in any way violent or respecting the rights of the people, they address and give us the opportunity to interact with those drug users and to better identify the needs that they might have, either in terms of treatment or other kind of interventions as social support or others. It's important to say that in our model, the coordination bodies are key. The responsibility for drugs policies in Portugal stands on the Minister of Health, and on his behalf, there's a national coordinator, in the case, the General Director of SICA. They work closely with personal representatives of 11 ministers in a almost daily basis, so we can establish and define priorities to act.
Sorry, next up we have Emily Milliken.
Thank you very much, and thank you very much, Chair and Dr. Goulau. I think that I think I'm actually going to build a little bit off of what MLA Amory mentioned. He sort of got into a little bit with regards to police and the idea of illegality of drugs in Portugal and decriminalization. I just want to be clear that a lot of people, when I talk to people here in Canada and we talk about Portugal and decriminalization, a lot of people just assume that it means that people in Portugal are essentially free to use for personal use drugs. A lot of people just take that as sort of what it means. I think that it's fair to say that clearly in Portugal drugs are illegal and prohibited. I think that, again, the word that I think that you used was forbidden. Given that, that means that if a police officer does catch somebody who is in possession of drugs, no matter the amount, that individual can be arrested and brought to the police station. Is that correct? Yes? Thank you, sir. Can you then do me a favor and describe the process of what happens to that individual as they then go to the police station? What's the process once they go through those doors?
Okay, thank you. Well, the person is caught by the police authorities using drugs or in possession of drugs is conducted to the police station, where the substance or substances are apprehended. They are weighted by the officials, and if the amount is superior to the one that is calculated on the basis of personal use for 10 days, there's a table with different amounts for different substances. If the person has more than that, he undergoes criminal procedures as before. He's sent for the criminal justice system as before, up to the trial of the judicial system to produce evidence that he or she is trafficking or dealing drugs or in any way. But if the person has less than that amount of substances, is just intimated by the police, just gets a piece of paper to intimate the person to present at the Commission for Dissuasion of Drug Addiction, which is an administrative body under the Ministry of Health. And he must present in a 3 days delay. At the same time, the police officer sends a copy of that intimation to the Commission, so the Commission already knows that this citizen is going to show up. If he doesn't, there's a communication to the police authorities again saying, oh, this person did not appear at the Commission. Okay. This is the process to come there.
No, I have an unrelated question, so maybe I'll just.
Okay. Next up, we have MLA Stefan.
Great. So I just want to learn a little bit more about the Commission for the Dissuasion of Drug Addiction. We don't have anything like that here in Canada. So I understand that under Portugal's system, just correct me if I'm wrong, if you're arrested for possession of drugs, but you possess an amount that is low, that would be for personal use, as you've described it, then they are required to attend this commission. Is that correct?
Yes, it is.
Okay. And just a quick question. Is this commission unique to any other jurisdiction that you're aware of?
No, those commissions, and we have one of those bodies on each district capital. We have 18 in Portugal, plus one in Açores and another one in Madeira. And those commissions were created specifically for this endeavor. They are composed of 3 members. They act under the Ministry of Health. The 3 members are typically jurists, someone who knows about laws, a psychologist, and a social worker. And they have a team of support, a technical team, that interviews, collects an history of consumption, a history of social and family history. They may use some diagnostic tools in order to score if there is an addiction or just occasional recreational use of substances. So they produce a report that is presented to the commission, to the members of the commission, that interviews the indiciated. This is a quite distressed environment, I'd say. It's not a court, it's not a formal audition, I'd say. And the main goal for that audition is to identify what kind of needs does this person have. Is he or she addicted, in need of treatment? It is discussed. Would you like to undergo a treatment? Have you never tried to approach a treatment facility? Yes, I thought about that, but it's so difficult, so complicated. Do you think so? Would you like to start tomorrow? We have a phone call and have an appointment for you tomorrow, the day after tomorrow. And I would say that most of them accept to have that appointment. I'm not saying they are going to be successful the first time, but at least they have a face, they know, they have a referral that is active, and from now it's easier to undergo and to search for a treatment if they need it.
That sounds excellent. Thanks.
Most of people, hopefully, are not addicted. The vast majority of people who is presented to those commissions are not addicted people, are just occasional recreational users. But even then, the commission tries to identify any kind of factor that, along with drug use, may be present in the citizen's life and may benefit of some kind of support, some kind of help, either from the social or health services to whom he or she may be referred at this point. And this is the same mechanism, I'd say. Okay, I have no problems with drugs. I smoke a joint with my friends on weekends. But in any case, my parents are divorcing. My father just lost his job. Myself, I am facing some psychological difficulties. I am imbalanced with my gender choices or whatever. And I may invite you, would you like to discuss it with a psychologist? Would you like to have an appointment with a social worker that may help your family? So the aim is to interrupt a career that may lead to a more problematic use later on. I don't know.
Perfect. Thank you for that response. Next up, we have MLA Allard.
Yes, thank you, Chair, and thank you, Dr. Goulau. Your last comments were the perfect segue into where my head was going. In your presentation, you talked about, you had a slide that had about 150,000, maybe 148,000 people, and of that 148,000, just over 82,000 were identified to be non-problematic users, and about 15,000 problematic. I'm just curious, especially given your last comment, is there a statistic showing how many of the non-problematic are repeat back into the commission? And is there a trend to become problematic over time?
Thank you for your question. Yes, there are statistics. I don't know them by heart, but there's most of the people of the non-problematic drug users come back in the next year at least. And when in the second time they appear at the commission, the use of administrative sanctions may start.
That's helpful. That's helpful. And I want, that leads me to my next question. I wanted to know, you explained the general process of the commission. What I wanted to know is, can you describe for our committee today the type of sanctions that can be rendered if a person refuses to participate in the commission process?
Well, the person may refuse, may do not appear at the commission as scheduled. In that case, the commission refers the absence of the person to the police authorities again, and they may prosecute the person for disobedience. It is not for drug use, but for disobeying to an order. So they may incur in other kind of penalties not related and not applied by the commission.
Thank you.
Next, we have Emily Yao.
Thank you so much, Chair. And Dr. Goulau, thank you so much for taking the time to speak with us. We greatly appreciate your time, experience, and expertise in this matter. My question to you, sir, is we know that Portugal built a significant recovery-oriented system of care for people with addiction so that they can stop using drugs and begin to heal. Portugal's system includes therapeutic communities, opioid agonist therapy, and other forms of counseling and treatment. In your opinion, would the Portuguese model work without this commitment to a recovery-oriented system of care? Example, here they seem to, in British Columbia, they seem to just offer the prescriptions and the opioids, but not necessarily holding the people accountable to when they accept these drugs.
Well, I would say that one of the main characteristics of our system is the broad range of options that are offered to people who use drugs and to their therapists as well. So we have a wide range of models of therapeutic communities, for instance, that work under different models. And we have the capacity to address the person accordingly, with the main difficulties that he or she faces in their lives. We are dealing with a chronic relapsing disease, so it's possible that the first attempt, the first system to be used is not the most adequate to that person. So we have the opportunity, if things don't work on the first attempt, we have the opportunity to try again, and we never give up of that person in any case.
Thank you. Just to clarify, so in your opinion, if Portugal were to have simply decriminalized drugs, without having the recovery-oriented system of care that Portugal provides, do you think your nation's strategy in combating opioid use would be as successful as it is today?
No, sir, I don't believe we would have the success. Success comes exactly of this integrated set of responses. Decriminalization has had its virtues. The most important, in my view, is turning everything much more coherent with the idea that we are dealing with a health condition rather than a criminal one. So that's why decriminalization is important, and also the practical way that we have put it in place that allows us to consider those commissions I described as a tool for prevention, for indicate prevention. But it's important to have a referral network for which we can refer people, and that easily can find responses if they wish to treat themselves or to rebalance their lives by means of harm reduction facilities, for instance.
Emily Rosen.
Thank you so much, Doctor, for joining us today. Technology is amazing. You're over in Portugal and we are all here in real time. So I'm so grateful that we were able to connect because Portugal is a world-renowned success story. So the one question that I do have will sort of go along the same avenue that member Yao was on. I'm just wondering if yourself or your government has any data anywhere or that you're aware of any data to suggest that decriminalization of drugs on its own without any recovery-oriented supports around it has any positive effect on reducing overdoses.
Thank you for your question. It's impossible to establish decriminalization as an independent variable. We cannot say we decriminalized, we got those results. It's the whole system, the complete package that led us to this improvement in situation. Impossible to say it came from decriminalization. What we feel is that altogether, those different components of our policy worked and are still working quite well nowadays. But as an independent variable, it's not possible to establish. We tried, but we could not find.
Okay. Thank you.
Excellent. Emily, did you have a quick follow-up?
No, I am good. I think between myself and member Yao, we covered most of the questions. I think both of us probably had around decriminalization, so thank you.
Okay. I know we just ran out of time, but I had one more question on the list. Did Emily Allard, did you want to get that in now?
If I may, Chair. And again, thank you, Dr. Gulau, for being here. I have actually one follow-up from my previous and then one additional question. So I had asked you about penalties for those at the commission or consequences for those sanctions. But I'm wondering what happens to those that are identified as problematic users and they refuse to participate in treatment? What kind of sanctions do they experience?
Up to them. We have no compulsory treatment. We invite, we try to persuade them to accept the treatment, but they are free to refuse. They may say, no, I am not interested. Okay, go in peace. Please do not come back to this commission, let's say in the next 6 months. Otherwise, I will have to apply you a penalty as well as to the non-addicted person that we spoke before. In the first contact, usually there's no penalty, time to think, but if they wish and if they reconsider, they may come and ask to have to be addressed for treatment facility meanwhile.
And with respect to the dissuasion process, that if somebody is a repeat offender and they're identified as problematic, those penalties can escalate and become quite severe, no?
Yes, they may But most of the penalties are sought to increment the follow-up, to permit the follow-up of the person. For instance, one of the penalties, let's imagine someone who is HIV positive and is missing his consultations at the hospital, follow-up of. One of the penalties of the commission can be, okay, you must retake your consultations and bring me the evidence, a piece of paper showing that you are attending your consultations again. You must come here every 2 months, bringing the evidence that you are seeing your doctor for this endeavor. And this is essential, and this is something that may be used. That's why I said the vast list of penalties that may be applied may be adapted to the lifestyle and to the personal conditions of each of the citizens.
Thank you so much, and I know we're really pushing it for time, so this is my last question with your indulgence, Chair. Is that okay?
Have at her.
Okay. Activists in Canada are advocating for the government to provide prescription opioids and stimulants to those that want to use drugs free of charge and without a prescription in the form of take-home kits. Is this something that Portugal ever considered or would ever consider?
No, we have not considered yet, but I completely understand that this is a discussion going on. I think it's not easy, according with the international environment and all the treaties and everything that we have agreed upon at the international level. But anyway, the treaties are not written in stone, and those treaties consider that the use for non-medical use of such and such substances is forbidden. Nowhere it says it must be criminalized, but it's forbidden. But how to consider that prescribing substances to those who are dependent, who have a substance abuse disorder, prescribing them the substance they are dependent on, is it a medical use for substances or not? This is a question that I think deserves to be considered.
Excellent.
Mr. Chair, with your indulgence.
Yes, sorry, if it's the will of the committee, allow one more question, and it seems to be, we will allow one more question if we can keep it tight, because we do have a presenter waiting.
Yes, absolutely. Thank you. I should have started my last question, actually, Dr. Goulau, with just a couple comments. I know from your background you're a doctor, and I know that in 1997 you became the national director of the Network of Drug Treatment Centers in Portugal. That was 97, and then your presentation with regards to the new strategy, the integrated model approach, kind of brought us to 1999, so a couple of years in. So you were part and parcel with regards to creating the strategy in Portugal, which I think Member Amory might have called it the gold standard. It's definitely, I would agree with him, and it's a model of best practices, or at least people view it that way almost universally. So with that, taking us back to that so again, thank you very much. It's my honor to have the opportunity. That's why I had to jump in for another question. So thank you to the chair. So going back to that, the original kind of, when you were breaking down the original new strategy, 1999 and moving forward, I'm not sure exactly what slide it was, but you mentioned two of the sort of pillars, or I'm not sure that was the word, but two of the main focuses was demand reduction, if I remember correctly, and then supply reduction. I sometimes ask the really, really obvious question, why? So my question might be too obvious sometimes, but here it is. Why supply reduction? What's the point? What was your goal with regards to supply reduction?
Was to reduce the the availability of substances circulating on the market. So I don't know. There are some historical reasons for in Portugal that we had an explosion in drug use very sudden after our democratic revolution back in '74. Prior to that, and during the Salazar regime, drugs were not an issue in our country. But after the revolution, there was an explosion, mostly related to the return of soldiers and settlers from our ancient colonies. And suddenly, it was almost impossible to find a Portuguese family that had no problems related to drugs. In the first moment, there was a sudden availability of cannabis all over the country, brought back from the colonies and distributed freely for free for relatives and family and so on. But shortly after, some branches of international organizations introduced in our market all the other substances. Suddenly we had everything, plenty of cannabis, but heroin, cocaine, LSD, you name it. And one of the concerns was the attempt to avoid that those branches installed in Portugal and became solid and completely established, mostly dealing also providing the access to drugs to other parts of Europe. We are very exposed in terms of the coast and the possibility to enter the country. So one of the concerns was exactly to try to avoid those organizations to consolidate in our country. And in fact, after decriminalization, since the police authorities got somehow free of all the tasks related to mere users, they could concentrate their efforts and their means, their capacity in big criminal organizations instead of dealing only with the mere users or street traffickers. So, and by the end of the year nowadays, instead of seizing grams or kilos at street level, they seize tons in open sea and big shipments in containers. Of course, they had to change their way of acting. They improved a lot the cooperation with the international counterparts, but nowadays they are much more efficient than before in countering the bulk trafficking.
Excellent. Thank you so much, Doctor, for joining us here today and taking that much extra time with us to indulge our questions. We certainly appreciate your efforts and your presentation. So wish you a good day, and again, thank you.
Thank you, Chef. It was a pleasure. So, thank you for everything.
All right, next our presenter is Ms. Amber Fort, the Executive Director of Pasteur Place Detox Center in Fort McMurray, Alberta. Ms. Fort, thank you for being with us today. I apologize for the delay in getting to your presentation, and without further ado, I will turn it over to you.
Well, thank you, Chair. Can everybody see me?
No, we can't see you.
So my camera's not working.
Okay.
I apologize for that. But I just want to thank you for this opportunity to have a conversation with you about safe supply and just share our thoughts about what that would mean for a frontline agency like Pasteur Place. We are a 16-bed facility in Fort McMurray that provides various programs to individuals in early recovery. Our detox program, pre-treatment program, post-treatment program, and day program are all designed to foster change. We work every single day hands-on with people suffering with addiction, and we have developed a good understanding of what works and what doesn't to help our clients on their path to recovery. I'd like to start off the presentation by explaining the process for a person with opioid addiction who is accessing our services and what that would look like in the course of their stay with us. So 90% of our clients are self-referral, meaning they are calling us on their own behalf for a bed to go through the withdrawal process. When they call, our staff will complete a brief assessment and provide the client with the time to come in for intake. During the intake, more in-depth information is gathered about the client's usage, previous detoxes, medical issues, as well as any mental health concerns. This is when clients will disclose that they have been using opioids. Oftentimes, their addiction started with a prescription for pain meds like OxyContin. The very first question staff will ask the client is if they are connected to the opioid dependency program here in Fort McMurray or to the virtual opioid dependency program. If they are, staff would immediately call their clinic to get the process going with regards to Suboxone, Methadone, Sublocade, whichever they were on. If not, staff will talk to the client about the benefits of these medications and connect them to ODP or VODP if they are interested. Clients are typically initiated on Suboxone, though we expect more and more will choose Sublocade now that it's available. Pretty soon after their initiation, we see clients start to feel better and assessments indicate withdrawal is starting to subside. This is the moment where we have the ability to help facilitate change. We encourage them to participate in our day program. Day program is a 5-day facilitated group program designed to educate people on addiction, why they are continuing to do what they are doing, why they just can't stop, and what they can do about it. Clients are not always eager to participate in the program at first, but something happens when they do. Often people are isolated in their addiction and feel entirely alone in their thoughts and feelings. There is a tremendous amount of relief when they realize that other people are going through or have gone through similar things as them. Sometimes we hear from almost every client that as they progress through the program, that they do not want to use drugs and alcohol anymore due to the fact that it has ruined their lives and the lives of their family. They talk about deep shame and feeling worthless. For anyone who has ever looked into the eyes of a person who is in this place, I don't think those words fully describe it. That is why we will believe in them until they learn to trust and believe in themselves. Until they develop a little bit of hope, we will continue to try to empower and motivate our clients to see that they absolutely can live a life free of substances. This is when a lot of our clients start to think about treatment and they decide it may be the best option for them. They make the decision to pursue recovery. At that point, they start working with our client coordinator who gets them connected to treatment facilities in the province that are best suited for them. We've helped many people transition into treatment centers over the years, but it has been challenging. There are often long waiting times for treatment centers across the province. We would lose people because they couldn't wait, and another barrier to treatment was financial. Clients couldn't afford the cost of treatment. In 2008, in response to wait times, we developed our pre-treatment program. Clients who plan to go to treatment can stay with us at no cost until they transition there. Even with our pre-treatment program, it has been hard. We feel people should be able to access treatment when they are ready, and it should be free. That is why we are beyond grateful that our provincial government is transforming the system of care to make this a reality. The recent announcement that a recovery community is being developed north of Edmonton is a game changer for us. Having the ability to transfer our clients direct from detox to long-term treatment with no cost to the client will help us save many lives and get our clients on the path to recovery. What will not work in recovery is safe supply. At Pass to Place, we have some real concerns that implementing a safe supply would be counterproductive to all of the things that we are trying to achieve in what we do. One of the bigger concerns would be that people who are at the point of considering entering into detox would choose to stay active in their addiction by utilizing prescribed safe supply, thinking that it will help them. Often addiction is a symptom of an underlying issue. The majority of the time, that issue is trauma, and individuals are using substances as a way of coping with trauma that they have experienced at some point throughout their life. We know that in order to really truly heal, individuals must sort through and deal with the feelings and emotions of those past experiences. This is why treatment is vital, but they need to get there. I've heard time and time again from many clients that one small dose of their drug of choice instantly sends them into addictive obsession and impossible to resist cravings. From that point, they are totally preoccupied with how they are going to get their next hit. If they are enabled in this perpetual state of addiction by making access to these substances easier by prescribing them, then the concern would be people won't even make it through our doors to learn that they can live another way. There are many concerns that previous presenters to this committee have warned about, such as people continuing to utilize street drugs while receiving safe supply, selling the safe supply to get the street drugs, diversion and adding to the opioid crisis by creating easier access to opioids and causing more addiction where there maybe wouldn't have been to begin with, I worry that offering a safe supply of opiates will start practice of offering other substances like cocaine and methamphetamine. I'm very concerned about the messaging that our youth will receive around government providing a supply of drugs. As a mother of 3, I've had many open conversations with my children about the impact and consequences of using drugs. They know that if they decide to use drugs, they can die from it. They know that alcohol causes the most harm, including death, even though it's legal. I question what message our youth will pick up from legalizing and normalizing opioid use. One of the things we need to put more effort into is looking into long-term prevention strategies. We need to get our youth and educate them, put more supports in place now so that our doors are a lot slower in 10 to 15 years down the road. We also cannot give up on people struggling with addiction now, which is the message that Safe Supply gives. Every single person who walks through our doors and asks for our help needs to understand that they can change, and without a shadow of a doubt, we believe in them. If we prescribe an addict their supply rather than actually believing in them and showing them that there's a better way to live, they're going to get the message that we gave up. That would be a huge injustice to those suffering in addiction. I've had the opportunity recently to have conversations with some of the people who have gone through our programs. I have asked a few individuals what a safe, free, or even cheaper supply of their drug of concern would have meant to their recovery. Unanimously, they all agreed there would be no recovery. I have permission to share some of those words and thoughts with the committee. One former client who just reached 9 years sobriety said, "In my active addiction, if I was able to have a safe supply of my drug of choice, I would never be recovered. I would have less incentive to get well and most likely would have kept me using drugs for longer. I was a street-level drug addict who was homeless 12 months of the year at the end of my active addiction. If the government gave me a supply, I would have likely used it in between seeing the dealer or literally sell the government supply to get a fix on the streets. If I had to guess, I would be in prison or dead by now. I needed detox, treatment, complete abstinence from all alcohol and mind-altering substances. I needed a 12-step program and a fellowship to be part of. Quite simply, I would not have ever wanted to quit if it was easy access to a free and so-called safe drugs." Another former client who's about to reach 11 years sobriety said, in my addiction, once I used, the craving would kick off and I couldn't stop. Every time I used, it gave me a temporary relief from my emotional unrest and kept me in obsession for more. I couldn't imagine my life without alcohol until I picked up crack, and then I was easily able to put alcohol out of my mind. It didn't matter what it was, whatever gave me the relief of my life problems, it worked. I had to look at life with a sound, reasonable, rational thinking mind. I find it hard to imagine that I would have found recovery if I was prescribed a substance that allowed me not to feel. I believe more in feeling reality with sound support like I got through detox and treatment working through a program. To me, a safe supply would mean a death sentence, and I would never recover. I now use different solutions to deal with my emotions and was able to learn that by taking the drugs and alcohol out of my life, you can't work on a solution until you understand the problem. You have to create a new life, and I believe not only you need support living, but you need supported living that holds you accountable. Being an addict in recovery, I see too many reasons why not to have a so-called safe supply program. I can see a lot of people coming to their bottom and reaching out for help, and then, oh wait, free drugs, I'll stop later. The last client was one of our post-treatment clients. His desire to help those who are struggling like he used to is nothing that I have ever seen before. A few days after he had sent me those words, he was at the center participating in morning meeting. Afterwards, he came to my office and he asked me one simple question. What about me? Does my recovery not matter? He said, the way I was in my active addiction, a program like Safe Supply would have kept me in my altered state of mind and my obsession, and I would not be where I am today. So does my life not matter? His life absolutely matters. I want to end by thanking the government for everything that you are doing to implement a recovery-oriented system of care. The system that is being created in this province is not only going to save lives, it's going to give people their lives back and reconnect families, leading to a stronger communities and a stronger province.
Excellent, thank you. Ms. Fort, certainly the personal story is very, very touching, very helpful, so we appreciate you sharing with us today. I'll now open it up to questions with the members. So first up, we have MLA Yao.
Ms. Ford, thank you so much for taking the time to speak with us today. I believe when we look at all of our presenters who all have frontline experience with treating addictions and opioid abuse, that they've all, you're certainly just one of the, currently the most closest to the front lines right now. And we really appreciate that, especially the fact that you're based here in Alberta. And the clinic that you work at, Past You Place, is it's a small and very intimate, but very effective clinic. So I want to thank you for your services there. Ms. Ford, the activists that promote safe supply concepts argue that treatment beds and addiction treatments are not the only ways to support addicts. And quite honestly, you might have already answered this question already in your introduction, but they talk about there being an entire spectrum of addiction and that we should be accommodating those who are not necessarily ready for traditional treatment. To that effect, how do you deal with people who might fit that description, that they might be on the far end of the spectrum in regards to being prepared for treatment? Do you have options available, or I wonder if you could answer that question.
Yeah, so one of the things that I would say to that is, there are people that are more ready for treatment than other people. We see it every single day. One of the things that we try to do in our center, and what I think is a vital piece that should absolutely be implemented through treatment across the province, is there's a piece between detox and treatment. And that is an area where, say a client comes in and they're not feeling the greatest and they start to feel better, and then they start taking our day program. So day programs implemented to educate them on why they're doing what they're doing and why they can't stop doing it. For myself, I wouldn't ever make a life-changing decision without knowing the ins and outs of why I should be making that choice. And so if we can get to people and explain to them, this is what addiction is doing and this is what, you can do about it, then sometimes, they say, maybe I do have this issue and maybe I do need help. The other thing that we do is we do work really closely with the ODP clinic and the virtual ODP clinic. So with regards to a spectrum, everyone that comes into our building is treated on an individual basis. We meet them where they are at, and we try to support them in that stage of their recovery, whatever that is.
Yep.
Thank you so much for that answer. And just to expand more on that, if you could expand more on those words you just said. One of our previous presenters, Chief Shirt, stated that safe supply does not address the fundamental addiction and mental health challenges that these victims are facing. To that effect, can you expand more on your comments that you just said about meeting people in their place where they currently are at and supporting them?
Yeah, for sure. So, the second client that had spoken with me, he talked about how he needed to have a sound, rational thinking mind in order to understand what was going on. So if we are giving people, these drugs that are keeping them in this state of mind altering processes, then they're never going to be able to have the chance to come in and actually have that rational thinking. Does that answer your question?
A little bit. I mean, basically, just emphasize that there are options available for people who aren't quite ready, and that does involve you and your services, as well as some proactive treatment, I guess, if you will, whether it's a therapy of some sort or helping them with some underlying issues.
Yeah, so what we do is if those issues are outside of our scope, we refer them to the addictions office, or we refer them to mental health offices, or like I said, the ODP clinic or things like that. We have a network of other agencies and other service providers in our community and actually throughout the province that we refer people to.
Excellent. Next up, we have MLA Milliken.
Thank you, Ms. Ford, for being here today. I also want to thank you for the work that you do on the front lines. I know from speaking to Tanny as well, I've gotten more information on the work that you do, and so again, thank you very much for that. Past Due Place seems to be, from what I've heard, an area where, lack of a better word, there's been some success there, and so so thanks for that. I know that within the, or correct me if I'm wrong, within Past Due Place, there's different availabilities for individuals at different stages of addiction, et cetera, and things of that nature, whether it's detox, day programs, pre-treatment, post-treatment. I think just in your most recent answer, you mentioned the potential of sending people to other agencies or other options that might be available that may not be at Past Due Place. In your experience, what is the most effective way that you've seen with regards to dealing with an individual's addiction? And I say that knowing that we've kind of already covered the fact that addiction can come in different ways or can have different factors for, people are unique. I'm assuming that individual addictions are unique, et cetera, but what, I guess if there was, would be sort of the most effective, and I'll have a follow-up to this too, what would be the most effective way by your estimation to treat addictions?
Treatment.
Treatment, okay.
Without a doubt, treatment.
Yeah, and I'm happy with,
There's a
no, go ahead.
small percentage, a very small percentage of individuals who can recover without implementing or going to a treatment program. You know, we see people come in thinking they don't need treatment all the time, and we kind of say, okay, yeah, you know, maybe treatment's not an option today, but if it ever is, come back. Majority of the time they come back and we end up sending them to treatment facilities.
Okay, just a quick follow-up? Yes. And I could, yeah. Prior to your presentation, having seen some of the background on Past Due Place and things of that nature, I just, a lot of people historically, and you kind of touched on this in your presentation as well, so I don't, but a lot of people consider or think of the beginning of the treatment process to often be when somebody hit, a lot of people use the word like rock bottom and things of that nature. I guess what I'm trying to get at is individuals, from my previous question I talked about how addiction can be different and people can be on a different, you mentioned people can be on a different spectrum with regards to addiction at any given time, et cetera. Would you say, like I said, a lot of people see it as rock bottom is when people then finally become open to the decision to say, hey, you know what, I'm ready now, and things of that nature. Is it also possible, though, that individuals along any part of a spectrum or as they go further into addiction, would there be potential for off-ramps at all stages, like beginning? Would it be like intervention or something along those lines? Taking into account the fact that you've also got, if anything, you've got within Past Due Place, you've got, say, day programs and all those other kind of detox, are there other options that are effective for people within the spectrum of addiction, not just necessarily when somebody finally comes in completely having broken their family or something along that nature, finally saying, okay, now I'm ready because I'm at rock bottom? Are there other off-ramps at different stages?
You know, I think that everybody's bottom line is different. I don't think anyone has the same bottom line. From what we see, the majority of people that are coming into the detox center, you know, their life is hard. That's what we see. And a lot of the times those people don't even know how to do the changes that they need to do, which is why we educate them. But I think I'm struggling answering your question because I'm not too sure what you're trying to say in that.
Okay. Let me try to rephrase it then. I'm happy to do that. Somebody who would be, okay. yeah, I'm struggling to then, I would say, like rock bottom, I guess what you said, rock bottom can be something different to a lot of people. A lot of people historically look at, say, somebody who is potentially going to receive safe supply, being that person who is maybe on the street and things of that nature. Are there opportunities for people at, you know, say if somebody has just started or somebody has, say, yeah, you're right, it's tough for me to kind of, I was trying to see if like, as somebody progresses down a spiral of addiction, are there off-ramps throughout that process that might be able to lead towards recovery without having to then only see them when they're at that stage where they come to you to say, hey, I need help?
Yeah, but those services need to be there. That support needs to be there.
Okay.
For instance, yesterday we were at the center, had a client come in who had gone through our program 2 years ago. She went to treatment for approximately a year. The last few weeks, she's been using crack every few days. She came in very upset, very crying, didn't want to step back into where she was previously. We called the treatment center next door to us, Fort McMurray Recovery Center, and we're getting her into the treatment center on Tuesday. This is something that the client knew she needed to do in order to get clean and sober. So I believe that there's many ways that we can kind of interject and kind of, you know, stop someone from maybe hitting what we would perceive as a rock bottom, but those supports and those things need to be there and people need to be aware of them.
Excellent. Thanks. MLA Allard.
So that's a great segue. Thank you for being here this morning. I'm from Grand Prairie, and one of the things I've noted is, and I think you touched on it, is the gap between detox and treatment. And so there are times when a client can come in to detox, and I think you were just talking about one, you're getting them in on Tuesday, but today is Friday. So what happens to that client in those few days? And I guess my question, bigger picture, is what tools do you need to better serve your clients to get them into a path of recovery?
So what happens to that client is we had a bed available, so we brought her in on our pre-treatment program, and she's currently in day program talking with, you know, the facilitator and a group of her peers, and really we're trying to just build up that confidence again for when she transitions into treatment on Tuesday. You know, when this woman came in yesterday, it broke everybody's heart because she had tried so hard. And I'm just really proud that she caught herself at a time and then asked for the extra help. The second part of your question, you know, day program and pre-treatment program, when we developed all these programs, it was because we seen the need in it. For someone to go into a detox center and sit for 5 to 7 days or whatever their withdrawal process takes and just lay in bed and eat and feel better isn't enough. We need to use that time, and we need to get to people when they're not feeling good, and we need to explain to them that we know a way where you never have to feel like that again. And the only way we're going to do that is through educating people, you know? And that's why I say, like, you don't know until you know. And you can't change something that you know nothing about. And so implementing these programs has really created this little mini continuum of care in our tiny little facility. And it's worked out really, really well. 90% of our people that admit into pre-treatment transition into treatment centers across the province. One of the things that we struggle with is the funding of these programs that we know work. We look for funding for day program yearly. We've gone to foundations, industry partners, things like that to fund it. And then United Way of Fort McMurray Wood Buffalo funds our pre-treatment program. But those are on a yearly basis. So every year, these programs are at risk of ending. And so financially, that's one of the barriers to adding these programs.
So if I can have a follow-up. So that that statistic is exceptional, 90%. And I guess what I wanted to summarize what I heard you saying earlier about safe supply is that in your experience as a professional in the field, you've seen people unable to make a healthy decision for themselves because, and I think these were your words, and forgive me if I'm misquoting you, but they're not in their right mind because they are in a mind-altered state from their drug use. Is that correct?
Mm-hmm.
Yeah.
So if you look at the words from the second client that I talked about, as soon as he got a taste for his drug of concern, that is all he thought about, was how he was going to get his next use, how he was going to be able to remain in that way, and how this is, if we put people in a position where all they're thinking about is how they're going to do this, how they're going to do this, how they're going to get high, they're not going to be thinking about the solution part and what life would be like without having to use that substance. They're just going to continue to try to find that.
Okay, thank you. I am not an expert in this field at all, and this committee has undertaken an exploration, a posture of curiosity, if you will, to understand from the front line, from those that are working in the field, what are truly the best practices in service to the people. And we're concerned, obviously, about the rate of overdoses, and we're also concerned about the growing issue with respect to drug use and drug abuse. So I heard you say earlier in a number of those testimonials that it is a disservice, so in my words, it's not a kindness to give the addict another hit. Can you give us an alternative to safe supply then? I mean, I heard you say treatment repeatedly. Are there other tools that we should be looking at as a committee? Again, I don't want to purport that I have this figured out, but I'm trying to understand from your perspective, what would serve those clients better to reduce the number of overdoses and to get people truly on a path of recovery?
Mm-hmm. So, and I think those are already available with Suboxone, methadone, and Sublocade. Those medications, when we have clients that come in and the withdrawal from opioids is terrible. It's not nice. It's not pretty. People are really, really sick. You hear people describe it like it's a flu. I would say it's nothing like a flu. They are in pain. Their joints are sore. I had one female client, and this client was actually the first time that me and our client coordinator have ever seen somebody dose on Suboxone. And she came in and she was in her mid-20s. And she was just in so much pain that she couldn't even communicate how bad she felt. And so we called the ODP clinic in Fort McMurray, and we got her there. They dosed her. Within 2 hours, she was up out of bed talking to staff and doing her hair and washing her face. And so a detox that would usually take days was shortened because of this medication. And then in that, she was able to withdraw quicker. She was able to enter into our day program quicker, where she was educated and she learned about her addiction. And then she was able to transition into a treatment center after that. So there are substitutions out there that aren't going to keep people in active use.
So thank you so much for answering my questions. I don't have any more. I guess I would just say what I just heard you say was that instead of a taste for their drug of concern, you're giving them a taste of success and what their life could look like without that drug of concern.
Correct.
Excellent. Any other members that have a question? Emily Yao?
First off, Chair, we have about a minute left. Looking for permission to extend this by just a few minutes.
Sure, for your question.
Thank you so much. Ms. Fort, you're in a unique position working up in Fort McMurray. Here in Alberta, we have a large Indigenous population, particularly in Fort McMurray. We also have the most successful and First Nations in the nation. They have demonstrated their entrepreneurial acumen. They're all business people. They're considered the wealthiest First Nations. And I just want to refer to some comments made by some of our previous presenters, and I just want to know your perspective of understanding whether, and this is the question, whether safe supply will disproportionately affect a certain segment of our population, particularly First Nations. So one of the previous presenters, Dr. Mogus with the AMA, he was, I believe, from the section of addictive medicines, mentioned that we need to study this here, that we need to have safe supply here, and we need to do a pilot project here, despite being reminded that there are pilot projects or full-on safe supply endeavors happening in British Columbia and in Ontario, as an example. Following him was Chief Shirt, Eric Shirt, and he stated that the issues around safe supply will disproportionately affect First Nations. He stated that it affects that many of the people who are in the streets are Indigenous, and that, if I can find the quote, he basically stated that these are experiments on First Nations people. He stated that they should not be doing experiments on us, as in First Nations people. Currently in the legislature, we have a private member's bill coming forward from the New Democrats, from the opposition, which they're asking that our government identify race in all the various issues that we are addressing, so that we could help perhaps identify underlying issues that affect these people that might be race-based. So again, just to clarify my question, do you believe that if we were to allow safe supply, that it would disproportionately affect our First Nations peoples?
You know, first off, 60% of our clientele that we see coming through our center are Indigenous. I'm a firm believer in, you know, Indigenous people having a voice and being able to advocate for themselves. I believe that safe supply with regards to Indigenous people will impact. Safe supply is going to impact everybody the same way. Every single addict will be impacted the same way. The underlying issues as to why addicts come in and why addicts use drugs as coping mechanisms are different for everybody. So do I believe it would be disproportionate based on our statistics in our center? We'd probably have an increase to people using opioids who are Indigenous coming in. Yeah.
Thank you very much for that. No further questions.
Excellent. Thank you, MLA, and thank you, Ms. Fort, for joining us today for your presentation and for all of your work that you're doing up north in helping people recover from addiction. So we really appreciate you and your time and your presentation. Hope you have a good day.
Thank you.
All right, next we have up Research Services. Honorable members, on January 18th, 2022, the committee directed the Legislative Assembly Office Research Services to prepare a cross-jurisdictional scan of safe supply in Canada. The document was posted to the committee's internal website on February 11th, 2022. I would now like to ask Dr. Amato from the Legislative Assembly Office Research Services to provide an overview of the cross-jurisdictional scan. So Dr. Amato, I will turn it over to you.
Good morning. I have echo, one sec.
Oh.
Okay. I hope you can hear me.
Yes, we can. You sound great.
You can?
Yep.
Okay. I hope you have the copy of the cross-jurisdictional document. It endeavors to provide some information on safe supply across Canada, and it begins by defining the term. So it notes that most jurisdictions, in fact, use the term safer supply, but safe supply and safer supply can be used interchangeably. As explained on page 3 of the document, prescribing safe supply requires exemption from the Federal Controlled Drugs and Substances Act. The Controlled Drugs and Substances Act prohibits activities with controlled substances across Canada. Activities with controlled substances are only allowed by exemption from the Act. Most organizations across Canada offering safe supply do so by application to the federal government. If approved, organizations receive funding through the Federal Substance Use and Addictions Program. There appear to be 14 organizations offering safe supply services across Canada, and these are listed on the table on pages 7 and 8 of the document. Also, in the footnote on the bottom of page 8, you'll find a link to an interactive map showing various organizations providing services that are responding to overdose crises across Canada. And that's just for your information if you'd like to explore that map. Organizations offering safe supply are currently located in British Columbia, Ontario, New Brunswick, and also most recently in the Yukon. British Columbia is the only jurisdiction to make safe supply a provincial policy and became the first jurisdiction in Canada to expand access to safer supply in July of 2021. In October of 2021, the Yukon also announced its intention to expand access to medically prescribed safer supply of opioids. In January of 2022, it announced expansion of safer supply in and outside Whitehorse. I'm just going to say a couple of words about the appendices. So Appendix A discusses supervised consumption services. And supervised consumption services are authorized by exemption under Section 56.1 of the Controlled Drugs and Substances Act. The text of Section 56.1 is quoted for you in Appendix B. Appendix C is the text of the class exemption the text of the class exemption issued under Section 56 sub 1 that permits safer supply in Canada. I'll also perhaps, as I did, draw your attention to the footnotes throughout the document. So I've tried to provide hyperlinks to all of the sources that I've used, and that's just for your information should you wish to look at those sources yourself. Thank you very much.
Perfect. Thank you, Doctor. I'll now open up for questions from members. Is there any questions from members? All right, Emily Allard.
Yes, good morning. Thank you. This is extensive work. I'm sure you've been very, very busy getting this prepared for us, so thank you so much for doing that. We just got the document yesterday, so admittedly I've skimmed, but I haven't read through the whole thing yet. I just wanted to know, in your research, did you determine if there are a number of other jurisdictions looking at this issue at the present time? Was that part of the work that you did or no?
So let me say that I only found information with respect to that pertaining to the Yukon. So that's why that is there. So they issued a number of press releases and notices in October of 2021, and then again, as I was finishing the document in January. So there were things appear to be in motion there. I did not find corresponding information in other jurisdictions. That's not to say it doesn't exist. It's just that I didn't find it.
Perfect. Thank you very much. And I guess I'm just wondering, of the jurisdictions that are offering safer supply, is British Columbia the one that's been doing it for the longest?
No, I suppose, but we should be maybe careful about what we say, what we define as long. So the documents the citations I have from the federal government and the class exemption 56.1 dates from 2020. So none of this I defer to you in terms of what you would define as long, but this is all fairly recent in my view. And the British Columbia policy dates from July of 2021, and the policy document that I cite there, it describes a policy that is being implemented and in 3 phases. And so I believe I state this in the section on British Columbia in the document, but the first phase is 18 to 24 months. So if that started in July of 2021, they're still in that first phase. So everything here is very new, and referring to the last question that I just answered, I believe, the Yukon is still, in the very, very first stages of this.
Yes, and that's very helpful. I guess the point I'm getting at, or where I'm going as I think about this, is that we don't really have a longitudinal jurisdiction in Canada from which to draw conclusions about what worked, what didn't, what were the societal impacts. As government, you often have to think about what are the unintended consequences of policies that you put into place, and sometimes we don't know that for a decade, and so we don't have a jurisdiction with that longevity. But I will read this more thoroughly. Thank you so much again for your research. That's all I have, Chair.
Excellent. Thank you, Emily. Next, we have Emily Yao.
Thank you so much to you and your team's work in finding us some of this information. I just want to clarify one of the columns that you have in your, as you reviewed the projects across the nation that have received the federal funding. Geez, I'm just shocked that it's almost $40 million worth of federal funding on this. Is there any other funding sources that you identified, or was it specific to the federal funding?
That is all the information that I have.
Okay. All right.
Excellent. Did you have a follow-up, Emily?
No, just comment that 40 million is a substantial amount of money to be providing in our nation. So-called safe supply of pharmaceuticals. I find that disturbing. Thank you.
Okay, thank you, Emily. Any other questions from members for Dr. Amato? Nope. I see none. So thank you, Doctor, for joining us and for putting this together for us. And we will now move on to written submissions. Honorable members, a summary of written submissions received by the committee was posted to the committee's internal website on March 24th, 2022. I would now like to invite Dr. Amato to please provide an overview of the document. Welcome back, Doctor. I'll pass it over to you.
I believe this is actually the document that was just posted yesterday, and so I hope you do have it. So it's just a summary of the submissions that were received by the committee, and I'll provide just a very, very high level overview. So the committee received 76 written submissions in response to its call. 4 of those submissions were from invited stakeholders. The breakdown of the submissions is that 30 were in opposition to the provision of safe supply in Alberta, 30 were opposed to the provision of safe supply in Alberta. 12 were neutral on the subject and simply sought to provide the committee with information. And hopefully my math is correct, 4 additional submissions were other comments and did not address at all the topic at hand, which is safe supply or the opioid crisis. Perhaps I'll just say a word about the contents of the submission. So again, a high-level overview. So for those expressing opposition to safe supply in Alberta, the one stakeholder who commented talked about the present medical literature. With respect to public submissions opposing safe supply, they expressed a variety of views, such as opposition to using tax dollars to pay for safe supply, that safe supply could encourage use of illicit drugs, that public funds would be better spent on treatment, rehab facility, inner city organizations, and/or safe consumption sites, concerns about where safe supply might be provided, and experience with addiction. Those submissions that expressed support for the provision of safe supply in Alberta, 2 were from invited stakeholders. Invited stakeholders made recommendations to the committee on the introduction of safe supply, and also made recommendations with respect to consultation with other stakeholders. Public submissions also expressed a variety of views. Some of them made recommendations on implementation. Some expressed the view that safe supply prevents overdoses and saves lives, reduces medical costs, reduces criminality. Some expressed the view that safe supply would provide a solution to the unpredictable toxicity of the illicit drug supply. And others discussed the need for safe supply as part of a continuum of care, including mental health supports and other social services. Still others discussed experience with addiction. Of the 12 neutral submissions, they, as I said, sought to provide the committee with information. So they urged the committee to consider certain perspectives in its deliberations. Some of them advocated for safe consumption sites, and some of them expressed views about the committee's proceedings. I think that's a summary of it, and to answer the question. Thank you.
Perfect. I will now open up to members for any questions. All right. Hearing and seeing none, we will move on. So thank you, Dr. Amato, and for the work done here. We will move on to committee decisions for consideration. Number 6, matters relating to written submissions. So at our February 3rd, 2022 meeting, the committee invited written submissions from the public to be received by March the 4th, 2022. The committee received 75 submissions prior to the deadline. Submission 69 was received after the established deadline. Submission 75 was originally received prior to the deadline, but the submitter requested that a revised version be accepted by the committee the day after March 4th deadline. Additionally, I would like to note that Dr. Perry Kendall made a submission to the committee prior to the established deadline, but provided supplemental written information to the committee approximately 1 week after the March 4th deadline. I would note that Dr. Kendall was one of the invited stakeholders who was unable to make our presentation to the committee today. At this time, I would like to open the floor to any comments or motions in relation to how the committee would like to handle these late submissions. Are there any comments or thoughts on this? Mr. Yao?
In the event that there are late submissions, I think that we should accept them. I think that's fair.
Okay. Perfect. MLA Milliken?
Yeah, I would actually just concur with what MLA Yao just said. I think that we should probably, I think it's reasonable to accept them, definitely.
Excellent. So we would entertain a motion that the Select Special Committee to examine safe supply receive all written submissions made to the committee prior to March 14th, 2022. Would somebody like to move that motion? Excellent. MLA Milliken moves that the Select Special Committee to examine safe supply receive all written submissions made to the committee prior to March 14th, 2022. Is there any further discussion on this motion? All right, hearing and seeing none, all in favor, please say aye. Aye. Any opposed, please say no. That motion is carried. Honorable members, those who made written submissions to the committee were advised that their submissions and their names may be made public. At this time, I would like to open discussion as to whether the committee wishes to make the written submissions public on the committee website. Is there any discussion on that? Emily Yao?
I believe in a transparent and open process. I believe we should accept all submissions as well as put them online for review.
Excellent. So would you be moving a motion that the Select Special Committee to examine safe direct that the written submissions received by be made public with the exception of personal contact information and confidential third-party information?
Yes.
Excellent. MLA Yao moves that the Select Special Committee to examine safe direct supply. Sorry, safe supply. See, I just read what's in front of me. MLA Yao moves that the Select Special Committee to examine safe supply direct the written submissions received be made public with the exception of personal contact information and confidential third-party information. Is there any further discussion on that? Hearing and seeing none, I will call the question. All in favor, please say aye. Aye. Any opposed? Hearing none, that motion is carried. All right, section B, request for an issues and proposal document. Honorable members, we have now arrived at the point in our committee's work where we begin to turn our attention to deliberating and making recommendations that will make up our report to the Legislative Assembly. The committee has heard technical briefings from the Ministry of Health and the Ministry of Justice, oral presentations from identified stakeholders, and has received written submissions. It is common for committees to request an issues and proposal document to be prepared by the Legislative Assembly Office Research Services to aid committee members in their deliberations. At this time, I would like to open the floor for any comments, questions, or motions on this topic. Are there any comments, questions, or motions? We'd be looking for a motion that could read like this, that the Select Special Committee to examine safe supply direct research services to prepare a summary document of issues and proposals identified through written submissions and oral presentations to the committee pertaining to matters relating to its mandate. So moved. Excellent. MLA Allard moves that the Select Special Committee to examine safe supply direct research services to prepare a summary document of issues and proposals identified through written submissions and oral presentations to the committee pertaining to matters relating to its mandate. Any further discussion on this? Hearing and seeing none, I'll call the question. All in favor, please say aye. Aye. Any opposed, say no. That motion is carried. That moves us on to other business. Is there any other business that members wish to discuss? Hearing and seeing none, date of the next meeting. The next meeting will be at the call of the chair. If there is nothing else for the committee's consideration, I will call for a motion to adjourn. Emily Allard moves that the March 25th, 2022 meeting of the Select Special Committee to examine safe supply be adjourned. All in favor, please say aye. Aye. Any opposed? That is carried.